So today, we're starting with the digestive tract, GI tract, alimentary canal, a couple of different terms for it. This includes everything from the mouth, the pharynx in the back of the throat, that's your swallowing and also gag mechanism, esophagus, the stomach, the three parts of the small intestine, the duodenum, ileum, jejunum. The ileum being the third part, duodenum, jejunum, ileum is the order. The ileum dumps into the beginning of the colon, the large intestine, at the ileocecal valve. Here's the cecum with the appendix hanging off of it. Anterior, transverse, or ascending, transverse, and descending colon. The sigmoid colon, kind of shaped like an S, rectum, and anus. And it's all separated, each thing is separated by sphincters. Your mouth is a sphincter. You're able to pinch it shut. You have an upper esophageal and a lower esophageal sphincter to allow food to go into the esophagus, then to go into the stomach without it coming backward, hopefully. The pyloric valve at the end of the stomach, this antrum here is and the pylorus is here. This is really powerful pumping part of the stomach to push the stomach contents through the pyloric sphincter or pyloric valve into the proximal duodenum, pronounced both ways. The ileocecal valve is a type of a sphincter, and the anal sphincter, of course. You have an internal and an external anal sphincter. The internal sphincter is involuntary. It will open when food has to move down into here. The external sphincter is the one that you get to control for a while. Other parts of the digestive system include the liver, which has a lot of non-digestive functions, but its big job in digestion is to create bile, store it in the gallbladder, and then at the right time shoot it into the proximal duodenum so that you can start digesting fats. It emulsifies the fats in the digestion process. The pancreas, another really big digestive organ, it produces insulin and glucagon, which are not digestive, but it produces pancreatic juice, which has digestive enzymes for carbohydrates, fats, and proteins, dumps them into here, so you get bile from the liver, and you get pancreatic juice from the pancreas when the food first enters the duodenum so that you can start digesting it. The pancreas and the bile system also dump bicarbonate into this proximal intestine to help neutralize the stomach acid, which otherwise could eat holes in the proximal intestine. That should all be review from your A&P classes, but that's just an overview of the setup of the GI tract. Some of your enzymatic secretions, saliva can carry salivary amylase, which will help digest starches. The stomach secretes stomach acid and pepsin. Pepsin, it starts digesting proteins. You also release intrinsic factor, which is needed to bind with vitamin B12 so you can later absorb it in the ileum. It's the only way you can get vitamin B12. The small intestine secretes a lot of small specific enzymes to digest some sugars and individual small proteins. Pancreas is a huge secretor of carbohydrate, fat, and protein digestive enzymes. You secrete a lot of water. You have to reabsorb a lot of water in the process. Some terms that we'll be using. Stoma refers to mouth. So stomatitis is actually an inflammation of your mouth. But you can also have a colostomy, It's an artificial mouth put on the side of to empty the colon in case of colon cancer. Salivary refers to saliva. Esophageal. Gastric is stomach. Pyloric is that pyloric area of the stomach that right where it's going to empty into the proximal intestine. Enteric means small intestine. So gastroenteritis is inflammation of the stomach and the small intestine. The colon, colonic, colon cancer or a colonic fistula or something. Rectal for the rectum. Cecal for that cecum, the ileocecal valve, for instance, taking the contents of the small intestine into the large intestine. Pancreatic. And hepatic for liver. The wall of most of your GI tract is made up fairly similarly. Not the esophagus. It's pretty much a muscular tube to push stuff into the stomach. But at least the stomach and small intestine, where most of the secretion, digestion, and absorption occurs, has a tunica on the outside, a nice stretchy, rubbery outer layer to give it some strength. It has 2 layers of muscle inside, and one is going circular, one is going longitudinal, and it allows a lot of different pulsation properties for the small intestine. It has its own nerve plexus running all the way through it to help control the contractions of the GI tract. In the mucosa is the lining that is facing the lumen of the intestine where the food is, and the submucosal area is the area right behind that contains another nerve plexus that helps decide how much secretion from, of digestive juice or whatever, and also helps dilate blood vessels so there's more blood flow through here when there's food to absorb. Mucosa is secretion. The muscle layers are for mixing and propulsion. Again, this should be review from A&P 2, but I want to make sure we're all remembering what we're talking about here. Couple of movement patterns throughout the GI tract. Peristalsis, squeeze, 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 squeeze to move stuff along. Your esophagus does it to push food into your stomach. The stomach will do it to push it into the intestine. The intestine does it its full length to help move food along into the colon, and then the colon does it again. There are different names for some of these propulsive actions. In the large intestine, it's called haustration or haustral shuffling, because those big balls individually sort of squeeze and push food along or help squeeze the water out of it. The other movement is segmentation, and this is just a squeezing back and forth to mix the stuff with digestive enzymes, and especially in the large intestine to squeeze the water out so you have a solid feces instead of diarrhea. Here's a review of those GI secretions: mouth, the saliva, antibacterials, acid neutralizers to keep you from burning your teeth up, and salivary amylase, gastric, hydrochloric acid, this is in the stomach, hydrochloric acid, which will kill a lot of bacteria that you might have ingested and start denaturing your proteins so that pepsin can start the digestive process. Also, intrinsic factor for the absorption of vitamin B12. Pancreatic juices, carbohydrates, fats, proteins. The liver secretes bile. The gallbladder stores the bile and then squeezes it out when you have a lot of fat that you need to emulsify. And the small intestine has those specific enzymes for mainly disaccharides like sucrose, table sugar, and the like, and some small amino acid clusters, peptides. Absorbing water is, like everywhere else in the body, it's done with osmosis. So what you do is you move ions across, and then the water is pulled by the osmotic force of following the solute. We pump a lot of chloride in the digestive tract. You pump chloride, sodium follows because it's attracted to chloride. Now you have sodium chloride, salt, has moved, and the water follows by osmosis. Most of the water is absorbed in the small intestine, 6 or 7 liters a day. Last amount is absorbed in the colon to give you solid feces. Most nutrient absorption and digestion is in the small intestine. In fact, most of it is in the duodenum at the beginning. And micronutrients have a lot of their own transporters. Fat-soluble vitamins just move across with the fat when it gets absorbed. Other nutrients have some of their own transporters. Calcium and iron have some specific absorption mechanisms. In particular, calcium transporters are activated by vitamin D. So vitamin D is required for calcium to be absorbed in the GI tract. So when it goes wrong, here's some clinical things that happen. I mean, you vomit, you have diarrhea, you have nausea, pain, whatever. Anorexia that's not the disease. Anorexia just means you don't have any appetite. At a time you should. If you haven't eaten in a long time and you're not hungry, you're anorexic in that sense. Nausea, we know what nausea is, a very uncomfortable feeling prior to perhaps throwing up. Includes tachycardia, fast heart rate, hypersalivation, dilation of your pupils. Vomiting is a reverse peristaltic activity that takes contents of the stomach and even the duodenum and propels it backwards out through your mouth. And of course, pain. Vomiting itself involves a couple of stages. It is usually preceded by nausea, where you feel like maybe you're going to need to vomit, but there's no vomiting activity going on yet. Retching is the process of convincing the GI tract to reverse peristalsis and start moving stuff in the wrong direction. So you try 3, 4, 5 times. Sometimes you're not even successful on your first round and you feel terrible and you wish you had thrown up and you have to wait and maybe it'll happen again. So retching is the process of initiating vomiting before vomiting happens. Projectile vomiting often is not preceded by nausea or retching. It's just an explosive, sometimes several feet of projectile, projecting the contents of your stomach. It can happen to a baby, for instance, if they have an esophagus that doesn't reach the stomach. They put stuff in there and the esophagus will reverse and just blow it back out again. Constipation, infrequent defecation. Not everybody defecates once a day, but that's about normal. But 3-4 days is a long time to go, or very difficult, often very dry stools that are hard to move. Could be caused by neurologic problems, damage. If you have damage to some of your lower back nerves that control the parasympathetic activity of defecation, reproduction, urination, it can interfere with those. Or damage to those nerve plexes in the walls of the intestine that help control some of those things. Functional or mechanical conditions, if you have a blockage or a twist of the intestine. Very low fiber diet. Fiber is non-digestible, and because of that, it doesn't turn to liquid, so it stretches the intestine as it moves through. And when you stretch the intestine, it is designed to squeeze and move stuff along. That's how bulk laxatives work. So if you eat some fiber and it stretches the intestine, it makes the whole intestine more active and you move the food along better. Sedentary lifestyle, exercise helps you poop. Excessive use of antacids, preventing some of the digestive enzymes and stomach acids from doing their job. Changes in bowel habits. If you have a completely different kind of job and you're not allowing yourself to go to the bathroom for long periods of time, perhaps. Diarrhea is, of course, increased and usually very wet, loose stools. Increased volume and heavier because water is heavy. Osmotic diarrhea happens when you have things in the intestine that aren't supposed to be there. They're not poisonous. You just have too much osmotic force pulling water into the intestine. So if you have lactose intolerance, you can't digest lactose and absorb it like you should. It stays in the intestine and pulls water toward it, and you have diarrhea. Secretory diarrhea is where you have something on the wall of your intestine is actually secreting stuff into the intestine, usually caused by a virus, a bacterium, or a toxin, something like cholera. You're actually pumping chloride ions into the too many chloride ions into the intestine. They drag the sodium along with it. It all pulls water along with it, and you have massive diarrhea, secretory. Motility diarrhea, if you overstimulate the muscle or the nerve plexus that's controlling the muscles, sometimes with irritant receptors or some bad food or something, it will just stimulate the digestive tract just to become super active to try to get rid of the contents. Diarrhea over a long period of time can be lethal. You lose a lot of water, you lose a lot of sodium, you lose nutrients that you were supposed to absorb. And of course, pain is common if you have GI problems. Parietal pain are the membranes that surround the organs, the peritoneum, which is the big bag that surrounds your main organs, or smaller ones that surround the organs, can become inflamed. Visceral pain is pain from the organ itself, the viscera. Referred pain, you can have pain in your abdomen even though it's coming from a pinched nerve in your back, because nerves spread out their tendrils and go other places. It can refer pain to even, the front. GI bleeding can occur with ulcers, accident, swallowing a bone and having it poke a hole, getting shot. Usually it's because of some kind of an abrasion or wearing away or ulceration of the GI tract. It can be the esophagus, the stomach, or the duodenum. That's upper GI. If you do an upper GI series, you stick a tube down your mouth and you can see the esophagus, the stomach, and the proximal intestine. Lower GI, you go up from the other end and you're looking at the rectum, the colon, and maybe the distal part of the small intestine. So jejunum, coleum, ileum, rectum. And the easiest way to see it is if you either vomit up blood or poop it out. So hematemesis, emesis is vomiting. So this is blood in the vomitus. Hematochezia is blood in your stools. Melena is a black tarry stool, usually related to bleeding, the blood that has already kind of, coagulated and even been somewhat digested and forms this kind of a black mass. And occult bleeding you can't see. So you poop, you look at it, you vomit, you look at it, you don't see any, but if you test it under a microscope or test for blood cells, you find some. Here we have GI bleeding, one of the book's favorite things to do is have these flow charts. So upper GI bleeding, lower GI bleeding, esophageal varices if it's been stretched or split, a bleeding ulcer, hemorrhoids. You can have blood in the stools from hemorrhoids. Generally not a serious thing, but it could be from intestinal cancer, it can be from Crohn disease, some kind of intestinal inflammation. You can build up blood in the GI tract. You can fill up your stomach with it. You can bleed out. People die from bleeding internally into their own GI tract. And if that happens, if you're talking that kind of seriousness, cardiac output goes down, constriction of blood vessels, you turn very pale, maybe bluish looking, metabolic acidosis, and decreased blood flow to organs, organ failure, and so forth. If the blood is coming from part of the bowel or something that is actually supplying that part of the bowel can die from lack of blood flow. And you have an infarction or necrosis of the bowel, the liver, the stomach. What if you can't move stuff along in the GI tract? The main thing about GI physiology is you put stuff in, you do something to it, then you move it along. You do something to it there and you move it along. You do something there and you move it along. If you can't move it along, it's a big problem. Phagia, remember that term phagio, or means to eat. A phagocyte is a cell that eats other things. Polyphagia, remember in diabetes mellitus, you're hungry all the time. Dysphasia means you can't swallow properly. Okay, you can't eat properly, but what it really means is you can't swallow. You can have a mechanical obstruction, a functional obstruction. You can have a damage. You can have a big cancer in there that's blocking it, or you can have a lack of the ability to stimulate the muscles that contract, or the ability to release a sphincter to let the food go through. Achalasia can cause dysphagia by not allowing the muscle activity in the esophagus to work right. It's supposed to squeeze like this, and when it gets here, the sphincter is supposed to open and then close again. If it's not squeezing properly or not opening properly, achalasia. In this case, it's showing the lower esophageal sphincter is not opening, and therefore the food is building up in the esophagus. You might also have the inability to prevent stuff from going backwards. Gastroesophageal reflux disease is a big problem in our society. I mean, everybody's getting heartburn. Everybody gets esophageal ulcers. Your stomach contents, including the acids, push their way past the lower esophageal sphincter back into the esophagus, and the acid starts eating holes in the side of the esophagus. First it inflames it, and then it can cause ulcerations. Reflux esophagitis is if there's inflammation. A couple of things can do this. As you get older, none of your muscles work as well as they used to. So I've heard. Somebody told me that. Including your sphincters. So people get they become incontinent. They can't prevent themselves from peeing when they don't want to. Their lower esophageal sphincter gets a little weak, and the stomach juice can squirt back up in their esophagus. It's especially happens if there's a lot of pressure in the stomach. So if you eat a great big meal and then lie down and all that's pushing against the lower esophageal sphincter, there's an excellent chance you'll get some reflux. If you eat at 6 and don't go to bed until 9:30 or 10, then there's time for a lot of that to empty into the duodenum, and you don't have all that pressure pushing against the lower esophageal sphincter. You can also elevate yourself in bed slightly, so gravity helps keep the food from pushing up so hard. Heartburn is the pain in the esophagus. The esophagus is right here, so that's why people thought it was their heart. Regurgitation of chyme, if it makes it up into the esophagus, it's not uncommon for some of it to squirt back up in the back of your throat, and you have a little bit of stomach acid in the back of your throat, which is pretty uncomfortable. Mid-epigastric pain, especially if there's an ulcer. Another thing your stomach can do is herniate. We usually think of hernias as being the things that guys get, inguinal hernias, and the inguinal canal is a weak spot in the lower abdomen of males, and it has a tendency to bust out when they pick up something too heavy, and you have to get it stitched back up. But a stomach hernia is called a hiatal hernia. The stomach is right below the diaphragm. The diaphragm separates the thorax from the abdomen. The stomach is the first thing below it, and there's a hole in the diaphragm that allows the esophagus to go through to reach the stomach. Well, if there's a lot of pressure down here, or this is weak for some reason, part of the stomach can shove its way through up into the thorax, right between your lungs, right under the heart. And this is called a hiatal hernia, and this is sliding because it'll kind of move this way and this way and this way. Paraesophageal means beside the esophagus, and so part of the stomach is, instead of bulging up straight back, it's bulging off to the side. Surgical procedures can repair that. Pyloric obstruction, remember you've got the fundus, the body, the antrum, and the pylorus of the stomach. The lowest part of the stomach is the pylorus, and that's where it's supposed to empty its contents into the proximal intestine. Well, if it doesn't, if it's blocked, if it's been damaged and so that it can't do its job normally, if you can't push hard enough to get it through, if it doesn't open enough to let it through, then the contents of the stomach can't leave, and that's a pyloric obstruction. Epigastric pain, fullness, you feel like you're way over full, like eating a big turkey dinner. Nausea. Food that stays in there long enough starts fermenting and producing gas, and so you produce a splashing sound. Normally your stomach is full of fluid, and if you take a water balloon that's full of water and do this, it doesn't make any noise. But if it's half full of air and half full of water, it goes slosh, slosh, slosh. And so the succussion splash is if you move around a little bit and it splashes a lot, you know you have gas in your stomach. And it can cause vomiting because if it gets full enough and it can't go that way, it's got to go somewhere. Obviously, malnutrition if you can't get any food to move through your intestine. An ileus is an inability of some part of the intestine to move stuff on. It can be caused by an infarction, a block off of blood flow, a twisting of the intestine. It might cause some of the intestine to die. It might be a stricture there that just won't let it open enough. But a paralytic ileus means that you can't get that part of the intestine to actually move the stuff on. An obstruction in the intestine. Simple obstruction, there's a chunk of something in there that won't move. Functional obstruction means it's paralytic, damaged nerves, twist, or something. So intestinal obstruction, proximal to the obstruction, the intestine starts stretching out. Distal, it shrinks down because there's nothing in it. Pressure on the diaphragm, ultimately, if it keeps on going, it'll push up and actually make breathing difficult. Atelectasis, remember, inability to inflate the alveoli. Pneumonia, if you can't move air in and out of the lungs, pneumonia is a possibility. Nausea. And ultimately, if it's bad enough, all of the things that go along with not being able to absorb any nutrients, maybe rupture of an intestine proximal to the obstruction. Gastritis is inflammation of the stomach lining. Remember, gastric means stomach. So acute gastritis may happen if you get, you eat something and it just causes a momentary flare-up of inflammation on your gastric lining. Chronic means that you are eroding away some of the wall of the gastric lining. Generally, these type things are caused by either too much acid or too little protective mucus layering that's full of bicarbonate to neutralize the acid. And so the acid is able to start eroding away part of the wall of the stomach. And you can have an erosion or an actual stomach ulcer from this. And this brings us to the peptic ulcers. A lot of people have ulcers. Peptic ulcer means produced by the secretions of the stomach. So a peptic ulcer is not a gastric ulcer necessarily. It could be in the proximal duodenum. It could be in the distal esophagus because the stomach acid could be working its way past a sphincter and causing problems there. So you can have erosions or true ulcers. Once again, and I'll mention this a couple of times because it's important, you can make more stomach acid than you should. Zollinger-Ellison syndrome is an overproduction of gastrin, which is the hormone type substance that acts in a paracrine manner to stimulate acid production in the stomach, in the parietal cells of the stomach. So Zollinger-Ellison syndrome just means that you are making too much stomach acid in the first place. However, a large number of ulcers are not caused by the fact that you make too much acid. They're caused by the fact that you've worn away by some mechanism the protective mucus layer that protects your own stomach from its own acid. So the acid can work on the food in there and not work on your own stomach lining. Couple of things that can cause this. H. pylori, Helicobacter pylori, it's a bacterium that lives in you all the time, but can take over if something happens, that it gets out of control, a little decrease in immune system, something else happens to maybe damage that mucus layer, and the Helicobacter pylori kind of infests the area. And what they do is they essentially destroy that mucus lining that helps protect you from your stomach acid and allow you to start developing stomach ulcers. Use of too much aspirin or ibuprofen can do the same thing. The way that it works is not because aspirin is acetylsalicylic acid. It's because it decreases the amount of protective mucus that you have and promotes possible stomach ulcers. Cigarette smoking causes an overstimulation of acid production as well. Gastric ulcers are most often developing they develop in the antrum and pyloric regions and up toward the sphincter. The sphincters have a lot of action that can move mucus out of the way and make themselves susceptible. Also, in the antrum, you have a lot of acid-secreting cells, so if you're ever going to develop an acid problem, it could be right there. Here's a duodenal ulcer where the acid from the stomach has gone into the proximal intestine, hasn't been neutralized well enough, and starts eating holes in the intestinal wall. Gastric ulcer, H. pylori, not enough bile salts perhaps, NSAIDs like aspirin, too much alcohol damages the lining of the stomach and causes inflammation too. Ischemia, if you actually have a blood flow problem to part of the stomach. The mucosal cells moves down. You reduce the quality of the mucus barrier. The acid then that's supposed to stay in the stomach moves back into the wall of the stomach, and you start causing inflammatory processes that will eat holes in the wall of your stomach. A stress ulcer it's not just because you're stressed out, although, you know, severe psychological stress definitely has ulcer causing capability too. We're talking about a real severe illness, systemic trauma, sepsis, you go into septic shock, your immune system can't fight things properly, changes your hormonal balances and the like. Burns will do that, and they'll wind up causing changes in the mucosa that allow ulcers to develop. Cushing syndrome is when you hit your head real hard, you get brain swelling, and the pressure causes a decrease of flow through the brain stem and into your brain. Causes a couple of major nervous system reactions. Causes your blood pressure to go sky high to try to push some blood into your brain because it won't go there. It causes, you know, a combination of sympathetic and parasympathetic outflows that are designed to try to keep your brain alive, but they throw the balance off everywhere else in your body. Ectomy means to take something out. Tonsillectomy, appendectomy. So what's a gastrectomy? Somebody had part of their stomach removed because they want to lose weight. Bariatric surgery, it's called. And there are a variety of things that can happen to you if you remove a big part of your stomach. One is called dumping syndrome. And what this means is as soon as you eat something, it just goes right on through into your intestine without being processed by your stomach first. You don't have enough stomach to process it. And you've lost your pyloric sphincter, or the ability of it to function properly. And so the food that you have goes into the intestine too soon before it's actually ready to be digested properly. Alkaline reflux, gastritis. If you lose your stomach cells, you lose the ability to make the stomach acid that's normal amounts of stomach acid. Diarrhea, largely from improperly digested food, weight loss. And malabsorptions from not being able to digest properly would lead to anemias, maybe bone disorders, maybe calcium deficiencies, whatever. Some more identifiable malabsorption syndromes don't allow you to absorb your nutrients. Well, there are a lot of things that can do this. You can have anything that causes inflammation to the lining of your intestine will prevent, it causes those microvilli to swell up and just smash against each other to the point where nothing can get between them, and you simply can't absorb the nutrients through them. The nutrients are supposed to be able to freely move between those microvilli to be absorbed. So an inflammation of the intestine will cause malabsorption. Maldigestion means that you aren't making enough digestive enzymes to digest the food in the first place, so it can't be absorbed. So if you have pancreatitis, where you can't release those pancreatic enzymes in there, then some of your food doesn't get digested, and therefore you can't absorb it. So you may not have an inflamed wall of your intestine, you just don't have food in there that's absorbable at that point. Normally, if you have maldigestion, you're going to have some malabsorption because you're not digesting it well enough to absorb it. One cause would be pancreatitis. Pancreatitis just means inflammation of the pancreas. Inability of the pancreas to produce the proper amount of digestive enzymes. Could be a pancreatic carcinoma, a cancer in the pancreas that's blocking the pancreatic duct. Part of the pancreas being removed. Cystic fibrosis, which causes an improper movement of ions back and forth, not only in your lungs but in the GI tract. Pancreatitis is really well known for its fat malabsorption, because your stomach can digest proteins a little bit and your mouth can digest carbohydrates a little bit, but you can't absorb any fats without the help of your pancreatic enzymes. And without enough of those, you don't absorb the fats, you don't digest them, so you can't absorb them. They come out in your stools, and you have fatty stools, or steatorrhea is what it's called, steatorrhea. And you'll have fat-soluble vitamin deficiencies, A, D, E, and K. We know of lactose intolerance, lactase deficiency. If people lose the ability, and like 30% of the world's population does, by the time you become an adult, you can't digest milk anymore. Milk, evolutionarily, it was only there when you were an infant. After that, you didn't need to digest milk anymore. Societies that developed a reliance on milk, yak milk or whatever milk, throughout their lives, mostly maintain their lactase production possibilities. I like milk a lot. I've drunk it my whole life, and I still obviously make lactase because I digest it just fine. But if you go a long time without drinking milk, there's a good chance you'll become lactose intolerant, and sometimes you just do just because it's who you are. What happens is you don't break down lactose at the intestinal wall into the monosaccharides that can be absorbed, glucose and galactose. So the lactose stays in the intestine. Your bacteria in there love it. It's sugar. They eat it. And they produce a lot of hydrogen gas as a process, which gives you the other lovely side effect of lactose intolerance. So not only we have stuff in there pulling water so that we will have diarrhea, we also have a lot of gas too. Osmotic diarrhea. Maybe you don't make enough bile salts. Well, if that happens, you can't digest fat as well because you can't emulsify the fat in the first place so that you can digest it and then absorb it. You can have any number of liver or bile duct diseases or inflammations or blockages that prevent the bile from being produced or making it to the intestine. Bile is stored in the gallbladder, and so you can have a lot of it when you need it. If you have your gallbladder out, which a lot of people do, you have to eat smaller amounts of fat at a time so your liver can keep up with the bile that's needed, because you're not going to get this big infusion of bile from the gallbladder. Steatorrhea, loss of fast-soluble vitamins, because they stay with the fat. So if it goes out with the poop, that's where your vitamins go. And, of course, deficiencies in fat-soluble vitamins take on several different, signs and symptoms and sets of problems. Vitamin A is important for a lot of things, but we know of it from its defense of the retina, maintenance of the retina of your eye. You would first notice night blindness or vision problems at night, later maybe vision problems altogether if you really had a serious deficiency. Vitamin D, if you can't absorb vitamin D because it's going out with your stools, you're not going to be able to absorb calcium either, because vitamin D is needed to absorb calcium. So you could wind up with a lessening of bone density as your body takes calcium out of the bones to keep your blood calcium high enough. Osteoporosis, easy fracturing bones. Vitamin K deficiency means that your blood doesn't clot well, because several of your clotting factors are vitamin K dependent. When babies are born now, they get a vitamin K shot so they don't accidentally bleed out. They don't wait to see if they have a vitamin K deficiency. They just make sure that right away they don't have any deficiency in vitamin K. And vitamin E deficiency, it's not exactly, the signs and symptoms are not specific. Vitamin E does help maintain connective tissue, helps maintain the integrity of blood vessels and so forth. But it's not certain that steatorrhea causing vitamin D loss would cause you signs and symptoms. At least not before way other things happen. There are a number of inflammatory bowel diseases. Some are chronic. People will have irritable bowel syndrome for years and years. Crohn disease, which is an autoimmune attack of your own GI tract. Some of them are genetic in nature. that have actually been shown to be a genetic defect that can be inherited. Immune reactions to your own internal intestinal flora, your own specific bacteria. It can be changed if you take a lot of antibiotics that might kill some of them. One of these is ulcerative colitis, which is an inflammation of the colon bad enough to cause ulcerations, and it becomes really painful. It can be infectious, meaning bacterial infection, or it can be autoimmune. A lot of your intestinal inflammatory problems are autoimmune. Now, if you have celiac disease, which means you are gluten insensitive, that can cause real serious inflammation. If you have lactose intolerance, that can cause inflammation. If you have Crohn disease, that can cause inflammation. If you get Montezuma's revenge, if you get, it's a bacterial infection. Dietary, you can eat things that are so toxic to your own system. Some people are sensitive to hot foods and cause inflammation that way. And serious inflammation, especially chronic inflammation, predisposes you to colon cancer. That's why you want to control it. You want to keep moving the food through, because if it sits still for too long, it tends to form toxins that start to make inflammation, and long-term inflammation, as we know from earlier in the course, are carcinogenic. Crohn disease. I've known a couple people that had this. Really not fun. And it causes these spots of inflammation throughout just about any part of the gastrointestinal tract. Causes blistering, ulcers and blisters or cysts to form. Very painful. Hard to tell that it's not ulcerative colitis, except if you find out that it was an infectious and you give them antibiotics and it goes away, then you know it's not Crohn's, because Crohn's is autoimmune. The bacterial comes in later. The autoimmune makes it easy for the bacteria to start working on this damaged tissue. Skip lesions. That means you skip a spot. Ulcerations. If you can't absorb vitamin B12 at the ileum, if it happens to be on the ileum here that's all inflamed and you can't absorb vitamin B12, then you get pernicious anemia. You actually have an anemia that we'll talk about later in the blood part of the course. Many people, maybe most people, develop diverticula. These are outpouchings on the wall of the colon. Now, I'm 65, so I recently had my second colonoscopy, and they discovered some diverticula. Okay, well, that's not unusual for a guy who's in his 60s. And diverticula, those are them. Diverticulosis means you have some. It's a condition where you have them. Diverticulitis is where they get inflamed. This is when it hurts. People with diverticulosis don't feel anything. They don't know they have it. You're just supposed to, be, they say, well, just don't eat a lot of things with little seeds like strawberries and tomatoes. Sorry, I eat a lot of tomatoes. If I ever get diverticulitis, though, you better bet I'll probably not eat any more tomatoes for a while. So they're outpouchings, just kind of little weak spots on the wall, kind of like older people get varicose veins and their vein bulges out a little bit. Here they are looking from the inside on a colonoscopy. You can see the outpouchings. Appendicitis, we know. It's actually called the vermiform appendix, which means it looks like a worm. And the appendix, of course, sticks down off the bottom of the cecum. It serves no purpose. There is some thought that at some time in the past it was bigger and more robust and helped digest something that we don't digest anymore, maybe bone or something. Now all it's good for is getting inflamed and killing people, because it can be serious. You know, if it gets so inflamed that it kills the end of it. You know, here's somebody, they've had a lot of intestine taken out. I shudder to think what this actually all involved, but there is the appendix. If the appendix ruptures, the contents of your intestine go throughout your abdominal cavity and cause serious infection, and it can be life-threatening. Good old irritable bowel syndrome. If there's no other cause, if it's not Crohn's, if it's not ulcerative colitis, if there's not an infection, if it's not appendicitis, if it's not diverticulitis, and it still hurts, it's irritable bowel syndrome. And it can be long-lasting, and it can be really painful. It can really mess up people's lives when it's bad enough. Anxiety, depression, chronic fatigue syndrome help increase this. It can cause a lot of diarrhea or constipation or alternate between both. It's a regular inflammatory condition that it's not especially well controlled. Digestive system number 1.